That's once again, of course, all these slideshow I give you to study stomach, duodenum, and pancreas together with the next one. Next one, it is this one. It is the spleen, small and the large intestine. Generally, we can say that we finished to study the organs of peritoneal cavity. Whole organs of the peritoneal cavity, we will finish today. I'm not sure that I will explain all of them for you, but anyhow, I give you to study. Now 1 minute attention to me. One of the most usually operated organs of the peritoneal cavity is the stomach. Stomach has very many surgical diseases. And the most usual problem of the stomach, which is sometimes, not always, but sometimes need to be surgically treated, we call ulcer disease of the stomach. By the way, ulcer disease by itself, it is therapeutically treated problem. You remember we make the combinational treatment, which is including antibiotics, proton pump inhibitors, the acid breakers, the antacids. There's a huge amount of the gastroprotectors like the Denol, yeah? But unfortunately for us, there are complications of the ulcer disease, which is need mainly emergency surgical treatment. And such complications is 5. There are 5 complications of the ulcer disease which is need to treat it surgically. Remember the names, please. First one we call perforation of the ulcer. Abdul, tell me please, what does it mean, perforation? Then you listen this term, what do you understand?
So perforation is like the ulcer goes.
Thank you very much. It is formation of the hole. How it's happened? By the necrotization, of course. In the region of the ulcer, if we will have complete perforation or damage of all layers, yes, stomach has 3 layers as you remember. Serous membrane, muscular layer, and mucous membrane together with some mucous layers, yeah? Generally, that usual ulcer located in the level of the mucus and submucous layers, but it can grow in the another layers also. And what we will have finally, formation, as Abdul say, aperture on the wall. By the way, we can have aperture in anterior wall. In that case, we will have flow of the stomach content to the big peritoneal cavity. Or we can have aperture in the posterior wall. In that case, we will have flow into the bursa ommentalis, or the small peritoneal cavity. By the way, I want to say that second situation is a little bit more dangerous. You know why? Because the dorsal peritoneum, which is covered the small peritoneal cavity, doesn't have so many nerves. And usually, peritonitis of the bursa ommentalis is not so bright and understandable, means the sign and symptoms is hardly recognizable. And you lose the time usually. How much time? After the problem will come, for example, to epiploic aperture or Winslow aperture, and will go into the big cavity. Unfortunately, during that time, the person can be dead. As you understand, because the peritonitis, it is huge intoxication of the human body. Yeah? All the toxins is absorbed immediately from peritoneum into the blood, and it gives formation of sepsis. That's the first problem we call perforation. Second one we call penetration. Now, can you tell me what does it mean, the penetration?
Spreading from one organ to another.
Super. Do you know what is the most usual direction of the penetration of the stomach ulcer? In your opinion, what is located very related near to the stomach? Well, you know, it is technically impossible because duodenum, it is continuation of the stomach. This ulcer will not run from the peritoneal cavity region. No. Immediately behind of your stomach, possibly by attachment to the posterior wall of the stomach, we have the head of the pancreas. As you know, the border between them, if she will be stomach, I will be pancreas, space between us will be called bursa ommentalis. But this is potential space. Then the stomach is full by the food. The stomach will touch the moon. Space will be closed because stomach will be enlarged to this free space. Yeah, will occupy this free space and will touch to the posterior wall of the bursa ommentalis. Very dangerous condition. I can say that one of the most dangerous complications. Why? Because it gives the autolysis of the pancreas. Pancreatic ferments is activated and they start to damage the tissue. And it gives the formation of acute pancreatitis, necrotization of the pancreatic tissue. Complication number 3, malignization. By the way, maybe single complication, which is need not emergency, but general planned surgical performance. Yeah, usually we don't make the emergency treatment of the cancers. We do the planned treatment. Maybe not only surgery, by the way, we can make all chemotherapy, we can make radiotherapy, and we must decide which method is most effective. We can make targeted therapy, but usually we use the combined treatments. Unfortunately, guys, in oncology, single treatment modality usually doesn't normally work. Only there are one exception. In the future you will study this cancer in situ. Cancer which is located in the level of basal membrane and which doesn't spread into another layers. For that kind of the cancer, the option is surgery. You remove it and in 100% it gives the 5-year survival without any problem. But for all other cases, we use usually combined method. But anyhow, what is the fourth complication? Obstruction, thank you very much. Then we have obstructional problem, especially it will be in the region of orifices. How many orifices have your stomach? You please. Name.
Pyloric and duodenal portion. Then
Pyloric
esophageal.
and duodenal portion. What do you mean? Pyloric aperture, okay.
Then towards the esophagus.
The cardiac aperture. Friend, they have names. We have pyloric aperture, we have cardiac aperture. Yeah, that's it. This is the most narrow parts of our stomach. If here we will have ulcer, what is happened usually with ulcer? Regeneration, scarification. The scar is formed, and this scar tissue make the protrusion into the lumen. This protrused scar can simply close, our orifices with formation of the obstruction. And last one, finally, bleeding. But if I don't mistake, we spoke about it, guys. But you say that I didn't explain your stomach. Okay, that's a remember, please. 5. Of course, guys, we can have just only the cancer without ulcer disease, and it also will be the cause of the surgery. What else, guys? Now use your fantasy and tell me, please, in your opinion, which other diseases of stomach will need the surgical treatment, except the ulcer problems, except the cancer problems? Vakul? Trauma, please. Great answer. For example, the perforation of the stomach by knife, by gun. Yeah, of course. It can need rupture of the stomach, yeah. I agree with you. Thank you very much. What else? Today is very widespread, one kind of the surgeries in the stomach.
Reduction. Stomach reduction. Sir.
Stomach?
Reduction. Sir.
What does it mean?
They will reduce.
Then we make the so-called sleeve surgeries. Yeah, then we make the stomach smaller for the purpose to lose the weight. Unfortunately, guys, you eat abnormally. You, especially then you a student, your food is absolutely abnormal. Time of the food intake also abnormal. Value of the food also abnormal. Volume of the food also abnormal. We suggest usually that it's necessary to eat small portions of the food and several times. Usually, best option it is 4 times approximately during the day. Why? Because if you, for example, hungry all the day and goes in the night in your home and eat very big volume of the food, it makes the hyperdilatation of your stomach, and during the time your mechanoreceptors, which is located in the wall of the stomach, lose sensitivity, and they start to irritate it only by very high dilatation of the stomach wall. Say you stand to eat the very big portions, of course it is formed the fat. And what is the meaning of this surgery? Mechanically, surgically, we decrease the volume. By the way, there are different methods, resectional methods, or from external, for example, bandaging methods, yeah? There are the special elastical bandages, yeah, which is prevent hyperdilatation of the stomach. The methods is different. I don't think that this is the good surgery because but unfortunately sometimes we don't have any other option. Also, we can mention, for example, congenital problems of the stomach. Yeah, for example, stenosis, atresia, congenitally, genetically. The child was born, and immediately after the first feeding, we see fontaine vomiting. What it doesn't mean? It means some part of the gastrointestinal tract, possibly esophagus, possibly stomach. By the way, how you can recognize is it stomach? If it is esophagus, guys, the time between feeding and vomiting will be very small, short, 6 seconds. Then it is stomach, by the way, we will have longer time, yeah, because you know the stomach provided storage of the milk, and it is stored during the long time, up to 1 hour. So we must understand, yeah, according to the time of the vomiting, of course, we have the great methods of investigation. We will make the X-ray by the contrast or CT scan with the contrast or barium swallow, for example, which will show immediately where is located this obstruction. But anyhow, even by physical some specificities, you can understand approximately the level of obstruction. Anyhow, guys, I don't have so much time to speak why the stomach is important for us. I think I prove you that this is surgically important part of the human body. And immediately now we will start to speak about its topographical specificity. By the way, I think you understand the consequence of the questions usually, which were asked to us to describe the topography. It's not so hard. Look, number 1, place of location. Number 2, relation with the peritoneum. Number 3, projections. Number 4, skeletal tapete. Number 5, syncope. Number 6, ligamentary system. Number 7, arterial supply with the place of location of the vessels. Number 8, it is the venous drainage. Number 9, it is innervation and the lymphatic drainage. That's all together called the topographical anatomy. Now let's start from the place of its location. Where is it? In peritoneal cavity. Which part upper? It is supracholic compartment of the peritoneal cavity. Remember, please, what is located above it? Yeah, it is not syncope. Just let's imagine what is above it. Above it, we have 2 structures. In the right side, liver. In the left side, diaphragm. Immediately. Let's say I understand where is located my stomach. By the way, stomach is directed from up to down and from left to the right side. What does it mean? It means that your left, if you will provide it midline of your body, upper orifice of the stomach, which is called the cardial, will be left to your midline. Lower orifice of your stomach will be right to your midline. It shows that the stomach goes, and of course, cardial aperture will be higher than polypyloric aperture. That's it. This is show for us direction of the food from the esophagus to the duodenum. It is directed from up to down and from left side to the right side. Is it understandable for you? Super, that is the position of the stomach. Now, relation to the peritoneum. If you will look, for example, in this picture, you will see that the stomach has a lot of the ligaments, and immediately the ligaments which I open now for you, whole located in the frontal plane. What does it mean? Now imagine that he is the stomach, for example. I'm the peritoneum. I come to him in frontal plane because your stomach also located in the frontal plane. I come to him from up to down. I split it into 2 layers. One my hand covers it anteriorly, another my hand covers it posteriorly. And of course, along the margins of the stomach has 2 margins, as you remember. One we call lower, lesser curvature. Second we call the big curvature. That's along these 2 margins, for example, his head, it is the lesser curvature. These, my 2 hands will become to each other, and they will form the ligament. So you can see that the superficial ligaments, otherwise the frontal ligaments of the stomach, located along the lesser curvature, along the greater curvature, and finally how it's covered by peritoneum, intraperitoneum. I cover him from all sides by peritoneum, except very small, the bind shape, 3 places, which is located along the lesser, along the greater curvature. Why we need this bind form or belt forms? Simply because vessels will be entered between my 2 hands, which I show now for you. Vessels and nerves will become to him and will be entered inside of the wall between these 2 layers of the peritoneum. And these non-covered places, anatomically, we call pars nuda. Pars nuda means the nude places, non-covered places, free places. By the way, along the lesser curvature, the width of this pars nuda twice bigger, up to 3 and 3.5 centimeters, than along the greater curvature. Also, pars nuda we have in the cardial region, mainly behind of the cardiac. Again, this is the ligament, especially the gastrophrenic ligament place, which is come from the diaphragm and fuse with the stomach and make the fixation of the stomach in its position. So remember, question number 2, we give the complete answer. Our stomach, it is intraperitoneal organ. It is covered from the whole sides. By the way, as you remember, I told you before that only intraperitoneal organs is movable. Second type of the organs, which is located in peritoneal cavity, it is mesoperitoneal organs. As you remember, mesoperitoneal organ is unmovable. Why it is unmovable? Now let's modulate it, the mesoperitoneal organ. I am the organ which by one my surface touch to the wall of the cavity. And now peritoneum from the wall of cavity will cover me from sides, then it will cover me from in front. I will be fixed to the wall. That's a conclusion about movement of intraperitoneal organ is very easy. The more will be the length of my ligaments, the more I will be movable. I can be moved only along of my ligament because my ligament finally will fix me. Do you understand me or no? Now let's imagine two parts of intestine. Both is intraperitoneal. First one, it is starting part of the jejunum, and second one, mid part of the jejunum. In the starting part of the jejunum, the length of the mesentery very short. It will not have the big movement. In the midpoint of the jejunum, length of this mesentery is 25 centimeters. That's why you can take this loop and into 25 centimeters remove it from the peritoneal cavity. That's why I prove now for you that the more is length of ligament, the more is movement of the organ. Remember it, please. By the way, in the next class, then I will speak about surgeries. You will see that I can connect it to each other. By the way, surgery which make connection, we call anastomosis. I can connect it to each other, only movable structures. Now let's modulate it with Abdul, why it is important. Imagine that head of the Abdul. His hand, for example, it is, I don't know, fixed organ, I don't know. Some part of intestine which is extraperitoneal, duodenum or something like this, I don't know. His hand is unmovable. My hand is very movable, intraperitoneal. I suture my hand to his hand. Of course, in the future, my hand will have the movement and the suture line will be irritated. Finally, of course, if the movement will be very big, we can have the ruptures of the sutures. Now, second situation, move now your hand together with mine. You can see if we move our hands synchronically, both is movable structures. I will not have the big pressure which is applied in the suture line. You can suggest me now, but you can say, sir, we can connect it to each other also to unmovable structures. It's possible, but it's technically very hard. Tell me why.
Because both are unmovable.
Because if I will make now this connection, I can apply it only by tangent. But by tangent sutures is forbidden, guys. Because I must to tense these two structures to each other because both is unmovable. Sorry, how else I can connect them to each other? And unfortunately, tangent which is applied in the suture line can give the insufficiency of the sutures. That's the best option which I can suggest you. It is connection between only movable parts. By the way, from that point of view, in my previous lesson, I told you that only superior horizontal part of the duodenum is movable. That's why if I make, for example, gastroduodenal anastomosis, for example, after resection of the stomach, I can apply it only by superior horizontal part of the duodenum. But let's imagine the situation that it's removed. Because, sorry, we have ulcers not only in the stomach wall, but in the duodenal wall, and it is immediately superior horizontal part of the duodenum. And if I remove the superior horizontal part of the duodenum, slowly anastomosis between stomach and duodenum will be impossible. You can ask me now what to do. Well, simply, guys, I will bluntly close the duodenal orifice, and I will make now anastomosis between jejunum and stomach. Gastrojejunal anastomosis. You understand me? That's it. This is important to imagine and understand. That's like if I can't connect it two structures to each other because one is movable, second unmovable, I will find the next part of the gastrointestinal tract. By the way, maximally near to the closed one. Yeah. And for my case, it will be the first loop of the jejunum, which is start from the flexura duodenojejunales. Yeah. I will take it, but I will have the problem here, guys. Because the jejunum will be located in infracolic part. Stomach will be located in supracolic part. That's why I will mechanically now lift this jejunum to upwards. I can do it differently. I can do it, for example, in front of transverse colon. I can do it behind by the rupture of the mesocolon. I can make the aperture in the mesocolon. You don't imagine, yeah? You are asleep now. You imagine what I speak? Huh? Please repeat it. What I say? How we can lift it, the jejunum to upwards.
By making a aperture in the mesocolon.
Or, so I say, or this or that. Or I can do it in front of our mesocolon. This is, look please, in front of, this is transverse colon. That is mesocolon. Put your hand below. This is the jejunum. I can take this jejunum and move upwards, in front of transverse colon. Or I can perforate it, the mesocolon, and move it behind of it. Listen to me, please. Do you understand it or no? But anyhow, guys, it will be single possible connectional method. Because if I will connect it movable stomach with unmovable duodenum, I will have the problems in the future. Again, let's come to the stomach. So we understand, second question, how it covered by the peritoneum. It is intraperitoneal. Question number 3, projections, skeletotopy, and syncope. Let's start from projections. I told you last time that stomach belongs to the unique organs. That is the organs which is located in peritoneal cavity, but projected not only into the abdominal walls, but into the thoracic walls. That's why let's understand in which abdominal compartments we will project it and in which thoracic compartments we will project it. Abdominal compartments is 2. One, it is proper epigastrium. Here we will have projection of the main part of the body of the stomach. And second one, it is the left hypochondrial region. Here we will have projection of the greater curvature of the stomach. So remember, please, from anterior abdominal wall, we have 2 regions with the stomach projection. Proper epigastrium and left hypochondrial. What about your thorax region, guys? In the thorax region, mainly it is the left anterior inferior thoracic region. Here we will have projection of the highest point of our stomach, which is called fundus. If you will look in this picture, you will see that the fundus located higher than the cardial aperture. Fundus is located higher. By the way, I imagine that you make my X-ray in the frontal direction. Yeah, I'm located vertically. You make the X-ray. Usually, what do you see in the right part, left part of the thorax? Air. And sometimes, if you are not so clever specialist, you think that the person has the pneumothorax. But if you will look attentively, you will see that this air located below the diaphragm, not above it. This is the air valve which we have inside of the fundus because by the physical forces, air goes to upwards. That's why remember, please, this air is absolutely normal. It is not any pneumothorax. It's located below the diaphragm, not above. But unfortunately, confuse you. Why? Because it is projected in the thorax. It is located behind of the ribs, not in the belly. Do you understand me or not? Okay, that's it. Once again, remember please, 1, 2, 3 places of projection. Now scale it at the peak. Now look to me. My left finger, I put in the level of the cardial orifice. My right finger, I put in the level of my pyloric orifice. You see, my stomach is not so big. By the way, it is of course for empty stomach. Then the stomach is filled by the food, so all these sizes is dilated, and your stomach will descend it up to your umbilicus. Not in proper epigastrium, but it will become to the umbilical region. Where is located my left finger? You can see, guys, where is it? It is located approximately by left parasternal line in the level of the 7 cartilage of the left ribs. Here. Where is located my right finger? Again, you can see it's located now right to midline or immediately by the midline, level of the 8 rib right cartilage, or strongly by midline, or 1.5 centimeter right to it. 2 points. Where is located fundus? Fundus located, guys, in the level of the 5th, much more higher. Look, if the cardia located in the level of the 6, 7, fundus located in the level of the 5th rib, now by middle clavicular line. That's a 1 skeletal point, 2nd skeletal point, 3rd skeletal point. My first point for fundus, my second point for cardia, my third point for the pylorus. Also, we can make projections of the margins of the stomach. Again, of course, for the empty stomach. Then the stomach empty. By the way, we don't have it real empty stomach. Because even if you don't eat anything, inside of it there are some amount of the juice, mucus, which is produced by the glands of the stomach. But anyhow, yeah, we say empty mean without food. How we projected the greater curvature? Usually along the bicostal line. That's why then the stomach is empty, greater curvature have much more horizontal position. How we projected lesser curvature? Now look, do you see this angle between my right costal arch and greater curvature, bicostal line? I draw the bisector of this angle. That is all projectional points of the stomach. Remember, by the way, you will need it not only for surgery. You will need these points to make palpation, to make the percussion, to make the punctures. Why not? That's why these points is very important, not only in surgical, but generally in the medical practice. Okay, next point, it is the syncope, relation of the stomach with neighboring some structures. To answer in this question, primarily I will remind you that stomach has some anatomical parts. That is not my subject, but generally remember 2 rings, 2 margins, 2 surfaces, and 4 parts. 2 rings, 2 margins, 2 surfaces, and 4 parts. Can you remind me the name of all of them?
2 rings, 2 margins, 2 surfaces, and 4 parts.
Now name each one.
Anterior surface and posterior surface we have. Margins, left and right margin.
No.
4 parts are cardinal, fundus, body.
No. What about margins?
Margin, anterior margin.
No. What about orifices?
2 cardinal orifices and
Once again,
cardinal.
you say 1. What about 2? Friends, I'm very sorry. I'm very sorry. Forget forever your option that the teacher asks you to confuse. I don't ask you to confuse. I try to find the relational fields. I try to find the common topics for the conversation. That is not so easy for me. That is very hard for me. Because imagine that you want to speak with some person about something. Tell me please, if you are absolutely non-informated about this topic, how you will make the conversation? How? That is impossible. You must have information for conversation. I say you every day that that doesn't appreciate it, such kind of the class. I don't like this kind of, I'm sure my experiences show that this kind of the class is not effective. What I mean that I say this kind of the class? I mean the class during which teacher is speak and students is relaxed. We have usually such kind of situation. I make some noise and you try to not sleep. This is awful. We must to have conversation. But to have conversation, you should understand what about I speak. To understand what about I speak, you need to remember your previous topic materials. For example, this question you study in your anatomy. If I will ask you now about functional specificities of the stomach, type of the glands, for example, you must remember your physiology. If I will speak about microstructural specificity of the stomach, you must remember your histology. But you know what the problem, guys? I cannot build my subject in the vacuum. I must to have the base. I cannot now start from the anatomy and finish by physiology and to give for you, introduce everything. Just my time, I know it, but my time will not be enough. That is the logic of all human life. If you need to make the next step, you must to do the previous one. Otherwise, you will try to jump, and usually the jumping is impossible, especially if there are the big distance. You must to walk. You cannot jump. Same here, friend. You think that the teacher wants to show you're confused? No. Absolutely, I appreciate it that I can have conversation with my students. I will tell you, two margins we call curvatures. It is the greater and it is the lesser curvature. Two orifices, it is the cardial and pyloric. Surfaces you mentioned, anterior and posterior. And four parts from up to down. It is fundus, cardia, body, and pylorus, which is divided into antrum and canalis pyloric. That's all. Now, why I mention this? Because then I will speak about the syncope. I must show the size of attachment, side of attachment, from which side it attaches, from which margins it attaches, from which part of the body it is attached. That is necessary to mention. Okay, now let's start from anterior surface. What is located in front of it? In front of anterior surface, now look please. We have three structures from up to down and from left up to right side. The most upper one, it is the dome-shaped diaphragm. Yeah, diaphragm is covered the stomach not only from upwards, but from in front. A little bit down and in left side, it is the left lobe of the liver. Last time that we speak of depressions in the visceral surface, I told you that the left lobe primary have the depression only of the stomach because they attach to each other. And finally, last part, it is anterior abdominal wall, which is also attached to the anterior surface. What is attached to the posterior surface of the stomach? Let's come now from right side into the left side. Generally behind of your stomach, we have the bursa ommentalis. That's like behind of your stomach, behind of bursa ommentalis, we have retroperitoneal structures. Which structures? From right to left, again, we will have head of the pancreas. We will have the body of the pancreas. Behind of the pancreas, we will have biggest vessels of human body. In right side, it is inferior caval vein. In left side, aorta abdominalis. I will have the biggest vessels of the human body. Truncus coeliacus, superior mesenteric, inferior mesenteric arteries. And the most left portion means the greater curvature portion. From behind will be related with left kidney and left suprarenal gland. Is it understandable for you? I think it's not so critically hard. Now look to the curvatures or margins. If you will look to the lesser curvature, you will see the lesser amentum, which is fused with it, and above it you will see the porta hepatis, visceral surface of the liver. If you look to the greater curvature, From up to down, you will see again diaphragm, you will see the spleen, you will see transverse colon and mesocolon. That is the structures which is related to the stomach from the side of the greater curvature. Is it so hard, friends? But I need the basement. If you don't know these divisions of the stomach, sorry, what about I will speak with you? Let's continue. This is about relation, otherwise we call it syntopy. Remember, please, we spoke about holotopy or projections. We spoke about skeletotopy, relation to the skeleton. And finally, we finished to speak about syntopy. Now one very important point, which is called the ligaments of the stomach. I want to remind again your anatomy, because you start to study it in time of anatomy. But you can ask me, sir, why it is so important for topographical anatomy? Answer is simple. If you make the surgery into any organ, doesn't matter which organ is it, first what you do usually, it is the mobilization of the organ. You must make it mobile, movable. How we achieve it? Usually by cutting of the ligaments. But unfortunately, guys, if you will just take the scalpel and cut these ligaments, you will kill the patient. Why? Because usually they contain vessels and nerves. It's impossible to imagine the surgery in any peritoneal organ without work by the ligaments. That's why ligaments have so big surgical importance. That's why I remind you anatomical topics which you studied before. All ligaments of stomach divided into two big groups. Group 1 we call superficial, otherwise frontal. Because all superficial ligaments of stomach located in frontal plane. Group number 2 we call or, thank you very much, you see, or horizontal. Because deep ligaments of the stomach located in horizontal plane, by the way, deep ligaments of stomach, only nutrition. Deep ligaments of the stomach, they have the forms of mesenteries because they start from the back wall and they come to in front to deliver biggest vessels and nerves from retroperitoneal space into the peritoneal cavity. Do you remember in my previous class I told you that these nutritional ligaments can have two types of positions. Position number 1 from back wall to organ, or position 2, or position 2. Again, the logic is located in the level of the floor. Of course. Friend, if you want to fly to your country, but we don't have direct flights, what you will do? You will make transit flight. You will come to one region, and then from one region will go to another. These our nutritional ligaments also work in this logic. If I don't have the direct connection between you and retroperitoneal space, we can have indirect. I will come to him, and he will pass the ligament to you. That's a nutritional ligament can be between wall and organ, or between two different organs. The greatest example for you, it is the lesser omentum, which is started from liver and come to the stomach and duodenum and deliver vessels and nerves. From organ to organ, not from wall to organ. Great example of the wall-organ connection, it is mesenteries. They started in the posterior wall and again they delivered the vessels and nerves into some organs. Remember guys, that is not so hard. Remember please, deep ligaments of the stomach. It is nutritional ligaments from the wall to the organ. There are two ligaments. One we call gastropancreatic, second we call pylorepancreatic. By the way, they located to each other like my two hands. One is located upwards, it is gastropancreatic. Second located downwards. One is come to the region of the cardia along the greater curvature, a lesser curvature. Second to the region of pylorus by the same lesser curvature. Is it understandable? In the upper one, gastropancreatic, we will have left gastric artery, which is originated from truncus coeliacus. And it should come to uppermost point of your lesser curvature, because after it will be moved along this lesser curvature from up to down, from left to right, and will reach approximately midpoint of lesser curvature, and will be directed into next ligament, which is called hepatogastral. That's why it is passed consequently inside of two ligaments. First one, it is the gastropancreatic. Second one, it is the hepatogastral. And it finishes inside of it. And it forms the arterial arch inside of it. Because it will be joined here with next artery, which is right gastric, from gastroduodenal. Let's say, remember, what is located in second deep ligament, pylori pancreatic. Much more bigger artery, which is again from truncus celiacus, which is need to come to superior horizontal part of the duodenum. Why? Because as I say, your pylori pancreatic come to the lesser curvature in inferior point. This is the border with superior horizontal part of the duodenum. And of course, it is the common hepatic artery. Common hepatic artery should come to this level. Why? Because in this level, it will give the gastroduodenal branch, which is split into the two branches, yeah? Pancreata duodenalis superior and gastroepiploica dextra. And then it should be renamed and called proper hepatic and will direct it exactly into the hepatoduodenal ligament, because from here we have the formation of the next ligament, part of the lesser omentum, which is called the hepatoduodenal ligament. And as you remember, common proper hepatic artery will pass with two another structures inside of this ligament. And these three structures together we will call portal triad. That is ductus choledocus, that is the portal vein, and this is of course the proper hepatic artery. By the way, they direct it from right to left in consequence of D, V, A. D, it is ductus choledocus, most right structure. V, it is the portal vein, middle structure. And A, it is the left structure, the proper hepatic artery. Friends, who else, tell me, just it's interesting for me, who else explain the topics of subjects for you in such a way like I do it? No, it's just interesting for me. Because any times I ask me question, how more effectively, how more understandably I can explain my topic for my students, because I want to be helpful for you. Okay, that's do you understand what is located inside of deep ligaments of the stomach? If I will ask you now, can you repeat it? Please, friend. What is located inside of the deep ligaments of the stomach?
Pylori.
Name the ligament and tell me what is located inside of it. Sorry? Then I spoke with you before. I spoke in such a way like you now speak with me. Friends, you are very clever, you are very talented, but unfortunately your talent is not directed into the medicine. Then I come to your parties and see your different kind of activities. I really appreciate it. But why you don't have so much activities in your education? Why your talent is mainly directed to sing the songs and to dance the dance? No, it's also good. But if I don't mistake, it's called a hobby. But sorry, I'm not sure that in the future this hobby will give you money. You will achieve your money, status, social level, if I don't mistake, by your main profession. Why for you main profession is less important than your hobbies? That is very interesting question, puzzle for me, which I cannot understand. Friend, now you're a really lucky person, you know. Or, do you know why you're lucky? Because you have teacher who is come to you and do the best to explain the medicine. For example, I told it for you before, yeah? My daughter now studying in Heratsi University. No one, I work in Heratsi 15 years. No one teacher didn't explain anything. They give the material, they say sit down and study. If you will have questions, come and ask. But again I say, you're a lucky person. Why you don't use your luckiness? I don't know, that is your business. Let's continue. Second group of the ligaments we call superficial, or as we say, frontal ligaments. Yeah? They are located whole in frontal direction. By the way, in this frontal direction, guys, we have finally 4 ligaments. From these 4 ligaments, 3 located along the greater curvature, 1 is located along the lesser curvature. So remember, please, 4 ligaments, 3 along the greater curvature from up to down, 1 along the greater lesser curvature. And from these 4 ligaments, only 1 is suspensor, all another is nutrition. From 4 ligaments, 1 is suspensor, 3 is nutrition. If you will look to this picture, you can recognize this first suspensor ligament in the highest place of your greater curvature. That is region of the fundus. And as you can see in the picture, this ligament connected diaphragm with the stomach, so we call it gastrocnemius. If you will a little bit descend it to down along the greater curvature, you will see second ligament, nutritional, important ligament. It is gastrosplenic or gastroleonal, call how you want. And it contains group of the vessels. First of all, it is short gastric arteries. As you remember from splenic artery, they come to the fundus, upper part of the greater curvature and supply it. By the way, same name veins will be drained into the splenic vein. Second artery, which is entering inside of this ligament, we call left gastroepiploic artery, again from splenic artery. Again, the same name vein will be drained into the splenic vein. Mirza, repeat it please. What do you remember about gastrosplenic ligament? Which vessels we have inside of it? Number 1. Left gastroepiploic artery. Tell me please, where will be drained the same name veins? What? My simple English stand ununderstandable for you, Mirza? Or you become to the option of the showman? But you make the show. I say the place of the drainage of the same name veins. What is ununderstandable for you? Minute before I explain it, what is ununderstandable? I told you that if the artery started from splenic artery, veins will be draining to the splenic vein. What's the problem? If you don't know, say, sir, I don't know. Why you show that you don't understand my question? If I will say you what is your name, again, you will show some confusion in your face. And you will say, I don't understand your question. Okay, let's continue. Let's say next immediately ligament, which is located along the main part of the greater curvature, between greater curvature of stomach and transverse colon. We call gastrocolic ligament. By the way, gastrocolic and gastrosplenic ligament, that is the parts of the greater omentum. As you remember, these ligaments descended to down. They fuse with the tenia omentalis, which is located in anterior part of the transverse colon, and continues to down as the greater omentum, which is covered all your small intestine. You remember 2 layers is descending, 2 layers is ascending, and finally we have formation of 4-layer structure, yeah? Without cavity, by the way. Cavity we have only in the fetal part of the leg. Then it was closed. What we have inside of the gastrocolic ligament, again 2 arteries, one is come from up to down, and it is terminal part of the left gastroepiploid. Previously we described it in gastrosplenic. And the second goes from down to upwards, or from right to left. We call it right gastroepiploic artery. And the midpoint of the greater curvature, again, formation of the arterial arch or anastomosis. That's why you can see now two anastomoses, yeah? One in the lesser, one in the greater curvature. About the lesser curvature, big, very important ligament, which is called the hepatogastral ligament, from the porta hepatis to the lesser curvature of the stomach. Its continuation to the right side we call hepatoduodenal. It doesn't belong to stomach. The name is sure that it belongs to superior horizontal part of the duodenum, but generally, guys, between these two ligaments, no any borders. That is one continuous ligament, partly fused with stomach, partly fused with the duodenum. Nobody didn't write any border for this ligament. By the way, a landmark border between stomach and between duodenum, it is the longitudinal vein, which we call Mayo vein. It is located immediately in the level of the pyloric sphincter. And usually we use it as the landmark for us, which is show the place of finish of stomach and place of start of the duodenum. Otherwise, you will palpate the wall of the stomach to find the muscular protrusion, which is called pyloric sphincter. Or, as I say you in my lecture, you can make, for example, X-ray by the barium, and you will see that this barium will pass through the narrow place. It will be pyloric sphincter. Then it will give the enlargement, which will be the bulb of the duodenum, the near 2 centimeters to the stomach, which is a little bit enlarged. Intraperitoneal, by the way, because next 3 centimeters of superior horizontal part, it is mesoperitoneal. As you remember. Time is, oh, we have time. Okay, that's it. Once again, let's come to the greater, lesser curvature of stomach. What we have inside of the hepatogastral ligament, I told you before, left gastric artery. It is firstly pass inside of the gastropancreatic ligament, then it reach the lesser curvature and enter inside of the hepatogastral ligament, and along the lesser curvature, it is directed into midpoint of it, where it is finished. Because in the midpoint, it will forms the anastomosis with another artery, which is also become to hepatogastral ligament from hepatoduodenal one. It is right gastric artery. As you remember, it is the branch of proper hepatic one. That's a common hepatic gives the gastroduodenal branch, renamed and called proper hepatic. And proper hepatic, before reach the porta hepatis, gives one descending branch, which is come to the lesser curvature of the stomach, from hepatoduodenal enter into the hepatogastral ligament, reach the midpoint of the lesser curvature, and form the anastomosis with the left gastric artery. Friends, I think it's not hard. It's not hard. All these arteries, all these ligaments, you must to find and you must to work during a resection of the stomach. A resection of the stomach you will do by 3 steps. By the way, it is the biggest surgery why I speak about it. Main surgery of the stomach. Causes of resection can be absolutely different. Starting from complication of ulcer disease, finished by the cancer or sleeve surgeries. That's a cause of the problem is different, but the treatment surgery is same, which is called resection of the stomach. And it will have only 3 steps, yeah? I speak technique of surgery, not access. Access will be longitudinal or transverse, doesn't matter. But 3 steps of technique. Step 1 you will call mobilization. What you will do during mobilization? You will cut the ligaments and ligate vessels inside of it. Step number 2 you will call resection. Then you will cut the part of the stomach. By the way, according to the necessity, we can cut different parts. We can make only pyloric resection. We can make subtotal resection. We can make total gastrectomy. On stage number 3, it is performance of anastomosis. That's why then we say resection. We understand 3 steps of the technique of the surgery. Mobilization, proper resection, and formation of anastomosis. And of course, all these ligaments with all these arteries you should find, you should recognize, and you should make some work, which we will study in the future. Let's say, friends, sometimes you think that the Mr. Arsene come and speak with you to complicate your life. No, I speak with you to help your life in the future. Because without this knowledge, you will be not responsible to do anything inside of the peritoneal cavity. And again, the most clever students usually say me, but sir, you know we will not work in the surgery. Doesn't matter. Okay, you will not work in the surgery, you will work in the, for example, like physicians or in some other practices. You must to make physical, for example, investigations, palpations, percussions, auscultations. Sorry, how you will do it if you don't know projection of the organ? How will you do it if you don't know position of the structure? That is impossible. Let's say, don't think, friends, that this subject is necessary only, no, mainly, but not only for the surgeons. Let's continue. Now, we understand everything connected with arterial supplement, and you can see the lower picture, which I explained for you last time. That is the venous drainage. You can see that along the lesser curvature, two veins join to each other. From upwards, you can see left gastric. From down, you can see the right gastric veins. They join each other. They forms the coronary vein of the stomach, which from hepatogastrial ligament come to hepatoduodenal ligament, and here it is draining to the portal vein. If you will look to the greater curvature of the stomach, you will see another veins. Short gastric veins, left gastroepiploid vein, right gastroepiploid. First two group of the veins drain into the splenic one. You can see when in the picture it is shown. Last vein drain into superior mesenteric vein. All these veins, by the way, you can ask me now, how they drain into these veins? Into the splenic veins, they drain immediately because from gastrosplenic ligament they come to the spleen and they drain into the splenic vein, which is located in the hilum of the spleen. Samely short gastric veins. But a little bit complication you will have with the superior mesenteric vein. How it will go? Again, pancreatic, gastropancreatic ligament. Because superior mesenteric vein located in retroperitoneal space, yeah? And this is the vein which is located along the superior horizontal part of the duodenum, or pyloric part of the stomach, pancreatic ligament. Through the pyloropancreatic ligament, they will be directed into the retroperitoneal space, where it will be drained inside of the superior mesenteric one, simply. Because, friends, this is important to understand, because your superior mesenteric vein doesn't locate it in peritoneal cavity. It is located in retroperitoneal. Splenic one, partly located in the portal vein, partly located in peritoneal cavity, inside of the hepatoduodenal ligament. But superior mesenteric one, no. And finally, you can, if you want to sleep, my dear, in my room we have the pillow. Go take it to have comfortable sleeping time. Wait, no. What about I speak now? What about I speak? What about I speak? Take all your bags and go from my room. Hurry up. I do it once. I will do it forever. Take you. If you don't listen to me, why you use my oxygen? Huh? Sorry? You will start to listen. Sorry, my lesson is finished. When you will listen? If you don't listen to me until now, when you will listen to me? In break time? In the break time, I will relax here. I will not speak with you. What? What about I speak? Please. If you will not answer in my question, you will immediately go from my room. Goodbye, friend. Take all your bags and leave my room. Friends, that is not the joke, yeah? It is sorry, if you need that, I need appreciate it to look in you. It is not so. I can go and to look, for example, some interesting movie or something like this. So sorry, what are you doing now? You come here for what? To show your beauty? Let's say remember, please, once again, if it is the veins which is located inside of the peritoneal cavity, we don't need to have the ligaments which is connecting the peritoneal cavity with retroperitoneal space. But if it is the veins which is located in retroperitoneal space, we must find the bridge. The bridge which is communicating the peritoneal cavity, and this is the deep ligaments of the stomach. This is the bridges which is connecting the peritoneal cavity with retroperitoneal space. That's all. Little bit about the lymphatic system of the stomach. Again, anatomy. You remember there are intraorganic, extraorganic. Intraorganics located inside of the ligaments. 2 along the cardial aperture, 1 right, 2 left. 2 along the pylorus, above and below. And 2 by midpoints of the greater and lesser curvature. 6 group of the lymphatic nodes. By the way, in the future you will use these groups to describe the metastasis of the gastric cancers. Because lymphatic metastasis will come primary into this 6 group because they drain the stomach body. So I mean the stomach tissue. From these groups, again by deep ligaments of the stomach, lymph will be directed into the retroperitoneal space, into so-called regional lymphatic nodes. Because the regional lymphatic nodes will be along the inferior caval vein. And that will be the second place of the drainage. About innervation, it's even funny to speak 2 trunks of the vagus, right and left, as you remember, with the branching, splanchic branches, liver branches, branches to the wall of the stomach. Parasympathetic, sympathetic will come from the plexus celiacus. It is superior splanchic nerves, which is come to the stomach and make its innervation. That's all. Questions? Study, my friends, study. Until